This afternoon, we're joined by Dr. Dwayne Proctor, President and CEO of the Missouri Foundation for Health. Dr. Proctor will share a vision of what it takes for us to achieve health equity this coming decade as we work to transform systems and eliminate underlying causes of health disparities and inequities. Prior to his appointment this past March, Dr. Proctor served at the Robert Wood Johnson Foundation in a variety of roles, including senior advisor to the president. During nearly 20 years in philanthropy, Dr. Proctor has always worked to ensure that American communities are healthy and thriving. He also serves as chair of the NAACP Foundation Board. Welcome, Dr. Proctor.
You know, when I started my job here, I made a bold assertion that we can achieve health equity in Missouri in the year, in 12 years. And I believe that's absolutely true. I've seen it happen in other places. And I think with a concentrated, focused effort and great attention to the ways bias, marginalization, and discrimination have shaped public policies that negatively affect health outcomes. And so that's the pursuit that we're on, and that's the goal to achieve. And we're going to have a good time doing it as we do our work. And so let's see, without further ado, I will share screen. Great. Thank you for your patience as I did so. So without further ado, this is me. This is the Missouri Foundation for Health. It's not me in the picture. You can tell, right? Okay, good. Let's move on. Hey, this is my hometown, my home city. This is Washington, D.C. This is where I grew up. This is where my father grew up. My grandfather grew up. I can do this all day long. We bought land in Washington, D.C. in the year 1728. So very much a part of the fabric of this city. And I grew up where, if you look at the number 77 in the middle of your screen, you'll see an orange and blue line that's going down. That's where I am from, right there on the banks of the Anacostia River. This map itself, if you've been to Washington and you rode our metro system, has our metro system imposed over life expectancies for the DC Metro Virginia area. The map was produced by Virginia Commonwealth University and with a grant from the Robert Wood Johnson Foundation. When I look at this map, what I see is a place where my family is scattered all over it. All over the Washington area, into Maryland, into Virginia. But I'm from right there in the center, and as are most of my father's family. And what I notice when I look at this map is I see unfairness. I don't think it's fair that if you live in the heart of the city, that your life expectancy can be predicted to be so many years lesser than in other parts of the city. I think it's unfair that a $2.50 ride on the metro can take you out to Fairfax County, where your life expectancy would increase by 7 years, or to Arlington, or to Montgomery County. I think Washington, D.C., if you're not familiar, is about 9 square miles. So it's not a very large city at that, and much of our land is occupied by the federal government. But where I'm from, in Anacostia, was always traditionally an African-American community. Anacostia is a place where, when I was growing up, we knew the merchants because they were next door neighbors. We knew doctors, we knew teachers, we knew people who stayed at home and raised children, like my grandmother, who babysat for maybe 10, 15, 20 years of children growing up on D Street, where we're from. We walked to schools safely, felt good doing so. We had fun. We didn't have a whole lot of grass in our neighborhood, so we played football and basketball in the streets. But for all intents and purposes, that was my home. That's where we're from, and it means a lot to me. When in 7th grade, my mother moved our family out to Fairfax County. And so if you look to the western part of the map, where the life expectancy is now 84, that's where we moved to. And what I was able to see living there was stark differences from my community in Washington, D.C. One, it was not as diverse as we talk about diversity today. Not as many African Americans living there. There were very few Latinos back in this day, and very few Asian Americans living there. What I also saw was that we had grocery stores, like 3 grocery stores within walking distance in any direction. I had 0 in Anacostia. We had greater access to healthcare. because hospitals were there and readily available and very large and able to accommodate the population that was there. The city hospitals in Washington, D.C. Were not like that. They were good, but they were different in so many different ways. And I think because I was young, one of the things I noticed the most was in the suburbs, young people had summer jobs. Young people had opportunities to earn money, to learn the value of a dollar, to start thinking about their roles as a worker as we grow up. And so when I think of unfairness and I think of injustice is why I focus on health equity. And that's why at the Missouri Foundation for Health, we're working to change this. So the Missouri Foundation for Health officially formed in the year 2000. We're what's known as a conversion foundation, meaning that there was a nonprofit corporation that was very important to Missouri that then decided that it wanted to be a for-profit corporation. And arrangements were made so that some of their largesse would be used to start a foundation that was focused on making change in health outcomes in the state of Missouri. So over the past 2 decades, our foundation has evolved from a traditional grant maker, as one might think, to what we call a change maker, those who are involved with making change here in the state, working with others to do so. Our mission is to eliminate the underlying causes of health inequities, transform systems, and enable individuals and communities to thrive. I will talk about these things in the presentation to come. We have 4 values, our core values that we hold in high regard, and we use them to guide our decisions and how we engage with people across the state. Those 4 core values are equity, integrity, humility, and commitment. And we use those core values to help shape our strategies and the way that we do our work throughout the state. And I hope that you see that in this presentation today, because it's not just those things for us are very, very important because it shapes how we enter a room. We enter a room with humility. We come in with commitment and integrity, and we always hold equity very high in the work we do. We don't think, and no one should ever think, that the Missouri Foundation for Health can achieve health equity in Missouri alone. We have to work with others, and that means we have to have others see us as a good partner to have, see us as an objective broker of information, and see us and our long-term vision and our strategy and understand why and how we do our work. We make change in 3 big ways. We contribute towards an enabling environment for improving health equity. We drive lasting systems change on carefully selected issues to prove what can be done if we all come together. And we promote opportunities to advance our vision and our mission. Lastly, you should know that, as I said, we work in collaboration, strong collaboration with communities, nonprofits, government agencies, businesses. We work with faith groups. We work with advocacy groups. We work with all those who think that they want to see the elimination of health disparities and address the structural causes for those disparities so that we can move on as we start to see change making. We collaborate with others, we share our knowledge that we learn with them, and we invest in our strategies. And this is where we work. This map is probably more familiar to you all than to me. I've been here all of 5 months, and I'm getting used to the landscape and the environment of this wonderful and lovely state that has so many riches anchored on both ends of the state and in between. But the colored areas that you see here are the places where the Missouri Foundation for Health works. Okay, now the gray area is an area that's outside of our jurisdiction, but we still care a lot about that. Our media messages makes it to that part of the state. We work with others from the other side of the state so that we can comprehensively approach how we achieve health equity, because we can't achieve health equity in a state in just our jurisdiction. We need to see this impact every region of Missouri. Now, I want to define some terms and get it straight, just so that we're all operating from the same place. This is a definition that Robert Wood Johnson Foundation uses to ground its work in health equity. It's not the only definition of health equity. It's the definition that Robert Wood Johnson Foundation used. And I should say that prior to coming here from the Missouri Foundation for Health, I worked at the Robert Wood Johnson Foundation, and I helped to develop this definition along with researchers and other scholars, Paula Braveman in particular, at the University of California in San Francisco. We developed this definition by first doing a literature review to see how health equity was being conceptualized by scholars in a number of disciplines across the range of academia. We did a content analysis on those definitions and also of speeches that we heard from others who were talking about health equity, so that we can look at this from the example of what people know and what they hear. Some of the definitions that we looked at were definitions that are appropriate for the Centers for Disease Control and Prevention. They have a very solid definition of health equity. This definition is not in opposition to that. World Health Organization also has a very, very strong definition of health equity. And the same I'll say for them is that this definition is not in opposition to it. However, when we looked at the variety of definitions around, we saw a few things that I want to point out in this definition here. One is the opening sentence. That's the ideal state that we want. We want everyone to have a fair and just opportunity to be as healthy as possible. But key in on those words, fairness and justice. Again, going back to my previous comments, I don't like unfairness, I don't like injustice. And so everyone having a fair and just opportunity points to something that needs to be accomplished. Secondly, this definition calls out the barriers, the structural barriers that are inhibiting people from being as healthy as they can be. And we point to structural barriers like poverty and discrimination as examples of the many structural barriers that may be in play as we think about health equity. And thirdly, this definition calls out the social determinants of health systems. The social determinants of health, public health term, is calls out the systems that impact all of our health, systems that are presumed to be helpful to others. Well, these systems also have discrimination and marginalization built into those things. And so we have to address those systems, root out the discrimination where it is, and also in order to get to a point where we can really think about eliminating health disparities. Eliminating health disparities is the ultimate goal. Health equity is a stop on that train ride out there to get there. We have tried, meaning public health, we have tried several ways to eliminate health disparities, many of which have been successful, some of which we're still fighting and continue to fight. But this nod towards health equity points to a different way of doing our work and a different way of measuring the outcomes that we're interested in. So you can't talk about health equity without talking about racial equity. And the definition of racial equity is quite simple. It's when one's race is not a predictor of life outcomes, statistically speaking, right? It's not good enough if I'm doing well and the rest of my people, however defined, are not, right? It's not good if 10 of us are doing well and the rest of us, statistically speaking, are not. So just casual observations of who we may bump into on our campuses, in our healthcare facilities, as we do our professional lives. If you cannot achieve good health in this country because of your race, that's racial inequity. So the idea is that your race should not be important when it comes to whether or not you thrive in a society. And so the combination of the two kind of looks like this. Racial equity and health equity so much overlap that we really have to address the fact that the disparities that we see across the country has racism as a construct here. If we know from the science that there are no there is no evidence of biologically inferior or superior species of people, but yet we still have inequities based on a belief that that exists. And that belief has started to affect our social policy and our public policy. And for the point of this conversation, health outcomes and health disparities in this country, then we have to look at this overlap. And it's where these two come together that is so important to direct resources. Without directing resources to where the problems are, to evenly distribute them across the country because of the very, very, very highly regarded ideal of equality, will keep us in the same situation that we find ourselves in today, that we found ourselves in 10 years ago, 20 years ago, and you can go back as far as you can think to 1619, when the first pirate ship arrived with 20 Africans, and their lives were controlled by public policy and social policy, and continues to be controlled in some ways for the last 400 years. But this is how this works. Intersectionality is really, really important here. So I've made the case that you overlap racial equity with health equity, but you also have to think about other forms of equity. People with disabilities need equity, and people of a variety of genders also need equity. And if I were to approach this looking at the intersection between disability and gender equity, it would be where those circles overlap that I would target the work. Targeting outside of there means that you may solve problems for some folks, but you won't get to some of the root causes that really brings these two circles together in this way. Now, when health equity and racial equity, you can do disability equity, you can add gender equity here, you can add all sorts of equity, but you never lose racial equity and its overlap with health equity as we do our work. The minute we look outside of those dark areas is the minute that we are, in statistical terms, introducing error into the model. And we have been very comfortable in introducing error into the models because we want to be fair, but not necessarily just for those who are on the other side. We want to be fair in equality sense, but not just in an equity sense. And so you overlap these circles, you never take racial equity out of it, and then you focus on the areas that are right there. I hope that I'm able to show you how the Missouri Foundation for Health does this in our everyday practice. Last definition to get straight is the social determinants of health. This graphic comes from the National Academy of Medicine and a document called Communities in Action, Community-Driven Solutions. And it was designed to show the different systems that impact people's health that need to be addressed in our work. For the National Academy of Medicine, they point to the transportation systems, the housing systems, employment systems, health systems and services, income and wealth systems, physical environment, public safety, social environment, and education systems. Really, really, really important to address systems. And I'm gonna play it out like this. The converse of health equity is not health inequities. A converse of health equity is structural racism. Racism that's built into the structures that control our lives. Those structures are made up of systems. These are the systems of concern when it comes to public health. So we address the discrimination that is implied in these systems in order to see the changes that we think we want to need. We're trying to fix and repair the systems that have been designed not necessarily to support health, but to get to a point where we can start to see differences in health outcomes and health disparities. Let's make this real for a second. These are maternal mortality rates from 2005 to 2017. The darker line on the screen represents the maternal mortality rates in the state of Missouri. The gray line or the lighter line on the screen represents the United States. And what you can see here is that that Missouri's maternal mortality rates exceed that of the United States. And that started around 2010 to 2012. You know, the United States is one of the 13 countries in the world where maternal mortality is now worse than it was 25 years ago. And leaning on that fact, we can see that things in Missouri are worse than they are in the rest of the country when it comes to maternal mortality rates. If we only went with this data and we wanted to solve maternal mortality rates so that there were no disparities across, this is not enough information for us. It only tells part of the story. And so then we have to look at where race comes into play. Now, this is a CDC diagram. What you'll see is the Hispanic government language. The Latino population is represented by the bar on the far left. It looks a little blue-gray to me from here. The bar next to it, which is lighter, is for our Asian American and Pacific Islander American peoples. The next bar over, looking more lavender, represents our indigenous populations. The dark purple one represents African Americans, and the light blue bar on the far right represents the white populations in the country. And what you can see here, one, is that African Americans have a higher disparities in pregnancy-related deaths during this time period than the other groups. You can also see how closely the indigenous population rates are to that of African Americans in these diagrams. And there's a significant difference between African Americans and all of the bars that are represented here. And so if you're really trying to solve for disparities in pregnancy-related deaths, and you want to solve disparities, then you would focus attention there in particular. One thing I do like about health equity is when we target and target appropriately, target our resources, target our attention, target our thinking. When we solve a problem using health equity processes to do so, the benefits are apparent for everyone. If you look at the Americans with Disabilities Act and what Policy Link and the Stanford Social Innovation Review call the curb cut effect, the ADA has allowed for us to have buildings that have special entrances. We push a button so that those who are using wheelchairs have easy access into the building. You got a curb cut on a sidewalk so that wheelchairs have access to our sidewalks easily. However, I use that button when I'm entering my office building if my hands are full. I pull my suitcase behind me when I travel, and I use that curb cut to get up on the curb. I've seen people do so with baby strollers and the like. So what was designed for one group of people is helpful to many. But if we don't design something for the people who are most at risk, most impacted by the issue that we're addressing, then what happens is we design something that's good for everyone, but not good for them in particular. And so overlaying the health disparities with the racial data, you start to see where you can target your resources better. Now, in Missouri, a state I'm just coming to love and know better, I found out yesterday that New Madrid County is actually New Madrid County, so that was new news for me. And but it also shows you how new I am to this state. But what I can tell you this is that when it comes to infant mortality in Missouri, we have an issue to take care of in St. Louis County and in the Boot Hill area of the state, because a third of the 6,200 Missouri babies born between the years 2002 and 2012, 30% of them come from St. Louis County and come from the Boot Hill area. And so again, now you can overlap geographic disparities, geographic inequities over racial inequities, just like we did before with gender and disabilities. And it tells you more about where to target your work. Now, targeting work is somewhat controversial, and mainly because we hold on to a very, very fundamental ideal of equality. It's like, well, if you want to solve the problem, you need to solve it for the entirety of the state. And I would argue that by targeting your resources appropriately, and I would argue based on experiences I've had and research I've done, that when you target your resources to where the problem is, you really do make a difference for everyone else who would be in that region in particular. When I talk about systems affecting people's outcomes, health outcomes, we can look at these very simple facts. African-American women with PhDs have the same chance of surviving pregnancy, right? And their child surviving pregnancy in the first year as white women who do not have a high school diploma. So if we looked at education as static, like the more education you have, the better off your health outcomes should be. Well, the facts actually deny that assumption. The facts are that the systems that we engage in, like the education system, right? That there's discrimination based in those systems, and it causes a lot of stress and pressure for people, especially those who stick in those systems the longest. And that stress and pressure, not just in education, but in dealing with other systems in America, have been cited as being involved in some of these high infant mortality rates and high maternal mortality rates that we see among African-American women, not just in Missouri and around the country. As a matter of fact, David Williams from Harvard University says that there is a 5-year difference in biological age among African-American women and white women in this country due to something called the weathering effect. And the weathering effect, just like it sounds, is that the pressure and the stress from engaging with systems that have discrimination built into them wear people down. It may be some of the reasons why we see such a low life expectancy in central Washington, D.C. when compared to the suburbs. So the Missouri Foundation for Health, we care deeply about the health of children and families. We work with a group called Flourish STL. They are a Missouri coalition that seeks to see the end of racial disparities in infant mortality by the year 2033. It is an excellent group to work with, and Flourish St. Louis has a comprehensive approach to addressing the maternal and child issues of mortality in St. Louis and in the Boot Hill area of Missouri. They do so by improving access to quality care and coverage, because too many Black women receive inadequate or late prenatal care. They focus on advocating for safer housing conditions for Black families, especially in public housing complexes, to better protect their health. They identify solutions to reduce a number of sleep-related as well as sudden and unexplained infant deaths in St. Louis. They convene other local organizations, and they are a coalition. They have over 90 different organizations receive grants from Flourish St. Louis to help advance that audacious goal of reducing disparities by 2033. They work with transportation organizations to help families get easier access to health care and supportive services. They partner with local home visiting groups as well. And there's enough studies to show that when you have home visitors helping to dispense health in your home, that it not only improves health outcomes, but also helps to lift families out of poverty. Those are the nurse family partnership studies that we can cite for that. But all of this is done so that mothers get to see their child's first birthday, something that is denied to too many mothers across the state of Missouri. And our hopes are that the work that we do with Flourish St. Louis would be something that could be picked up in other parts of the state once everyone understands how these different systems impact people's lives, and no one's life is unduly affected by just one system. It's usually the overlap of system, which is why Flourish St. Louis takes a comprehensive approach to addressing several systems as they do their work. Okay, so listen, there's going to be a test later about this slide in particular. Okay, so pay attention here. It has to do with your role in achieving health equity here in Missouri and across the nation, and the things that we all can do together. As I stated earlier, there's no way that the Missouri Foundation for Health can do this without engaging partners that represent all of the other sectors that also represent the social determinants of health. And so when we seek out partners and we start talking about what they can do, we talk about things like systems mapping, because systems are complex and interconnected. Systems mapping is crucial when tackling multifaceted problems. This requires identifying the entities that touch the issue and understand the relationship among these actors, and those relationships including the distribution of power, cultural norms and beliefs that influence decisions, and policies and practices to govern action. Imagine if we had done systems mapping like this prior to the COVID epidemic, the pandemic that we're in right now, if we understood that these things were going to influence and impact people's interest, willingness, and faith in the institutions that serve them and the science that is being presented. Imagine if we had already done that. So we need to do that. We can't just say we didn't do it in a moment when we know that it will be helpful in our future. Systems map shows who needs to be involved to develop interventions that will change in a positive way. We also need diverse coalitions. That means bringing together individuals and organizations from different sectors and disciplines, because everyone can bring their own unique skills and perspectives and expertise to co-design solutions that work. We have an initiative that we call Healthy Schools and Communities that brought together schools, community organizations, businesses, parents, and students to identify and advocate for changes to increase access to healthy food and physical activity for schools. Once again, having a diverse coalition means that all voices are there, but I want to be really, really clear that there are three important audiences that are part of that work. It's teachers who work, who work in those schools, it's students who attend those schools, and it's their parents. They have a voice, they have a say. When we engage people in that way, what we find is that that the risk of unintentional consequences and unanticipated consequences decrease, because people who are most affected by the things that affect them are the ones who understand the solutions and the systems and where the systems has failed them. We also will guide you towards building power in community. That means respecting the people who are in community as key experts and influencers in the work that we do. We need to engage those most impacted by the problem when developing our systems. If not, we're likely to run afoul. We have to be careful that our past methods of using, I'm going to call it extractive methods, to gain information and to develop interventions and programs and policies are not extractive. And by extractive, I mean we reach into communities. We reach into communities and we take what we want and we go back to our offices and we work with others and we design something that gets imposed on communities. In doing health equity work, it is very, very important to engage those folks and respect the power that they have, and to build power in the community so that the community has the capacity to always be able to address this approach, address this work. And lastly, data are what we need, but we need data that really speaks to the issue of the problem. It's no longer good enough for our studies to look at only two genders when we're doing our work. It's not good enough to say, this is what's going on in Asian American communities without understanding that the distinctions between the different countries and the cultures that come together are really, really important, because then we'll start to see health distinctions even within that ethnic group collective. And so using that as an example, we have to have data that really works in this day and age, and data that looks to address the systems that need to be changed. We've done a lot of work in Medicaid expansion that we're really proud of at the foundation. The work that we've done along with others, right? Other partners from health and healthcare, from advocacy, from policy groups, from community-based organizations, has us at a point now where 300,000 people last spring who were not eligible for Medicaid now have the opportunity to be eligible for Medicaid. And that is a way to expand, to decrease health disparities, but it started with a health equity approaches to get us to where we are. And we're great fortune to know that the Missouri Supreme Court has ruled that Medicaid expansion, as voted on by the people of Missouri, is now a thing. It's now real, and the doors are open for people to enroll, and especially folks who make less than $18,000 a year, who used to be in a gap between being able to get on Medicaid or other supportive services that are available to them. So here's the quiz I told you about, and it's good. I want to ask that you use your chat and answer as many of these questions as you're interested in answering, just to get an idea of how we may see our role when it comes to achieving health equity together, right? So what does health equity look like when it comes to your work? Please feel free to put your answers in the chat. I hope it's a vibrant discussion. I can't see it, but I hope it's a vibrant discussion. Secondly, what's one thing you're going to commit to advance health equity? Third, what will the state look like when we achieve health equity? So please choose among these three questions. You can answer one, you answer two, you can answer all of them, but it's really meant for all of us to kind of have an idea of what we see the possibilities are and what we're really willing to commit to. So that's my presentation for today. I'm Dwayne Proctor. You can reach me at any of these media that will allow you to do so. I'm happy to take questions, but I know that in the interest of time, because we have esteemed guests, I would just ask now that the panel join us, and so that they can further discuss these themes in health equity that are so critical in order for everyone to live their healthiest life possible. Nikki, the mic is yours.
Thank you so much, Dr. Proctor, for that insightful presentation. I'm really hopeful that our guests are paying attention to the homework, if you will, that you shared and are starting to think more critically about health equity in the state of Missouri. So hello, everyone. My name is Nikki Magruder. I am the Director of Diversity, Equity, and Inclusion at MU Healthcare. I am joined this afternoon with some special guests, and in the interest of time, I'm going to tell you who is joining us, and then as they begin to answer questions as we go along our afternoon, they'll be able to share more about the work that they do. So joining me this afternoon, we have MU Extension Health Equity Partners from the Center for Health Equity at UMKC, Dr. Jeanette Berkeley Patton. From the Middleton Center for Race, Citizenship, and Justice, Dr. Stephanie Shonikan. From the Missouri Foundation for Health, Ryan Barker. From the Columbia-Boone County Department of Public Health and Human Services, Verna LeBoy. So we are going to dive right in with just some conversation since we've just heard Dr. Proctor speak on health equity, and we want to key in on some of the things that we're doing, not only locally, but in the state of Missouri as a whole. So I'd like to ask our panelists, can we talk a bit more about the importance of equity? We just learned a lot about health equity. So can we talk about the importance of health equity or equity in healthcare versus the conversation around equality in healthcare? Because there's a difference that our attendees may or may not know about. Who'd like to jump in with that?
Well, Nikki, maybe I'll just start off because I'm going to just say a few words and then step back for the experts on the panel. So as Nikki said, I'm Stephanie Shonikan. I am co-director of the Michael A. Middleton Center for the Study of Race, Citizenship, and Justice. And so this opportunity to be in the midst of these experts is really valuable to me and to the center. Our center is only about a year old, almost exactly a year old. And our intention is to do work that may have some impact on the kinds of questions that Nikki is asking, and that I think we've been thinking about all day as we've been experiencing the new center here at Mizzou. So we at the Middleton Center, we are interdisciplinary. Our affiliates span the entire campus from the arts and sciences to law, to journalism, to the health disciplines as well. And so we will continue to promote the work that is represented on this panel. Part of our mission is to involve our community partners. And so I'm so excited to see Verna LeBoy here, Miss Verna, as we call her, and the kind of work that she does that will completely inspire not only our faculty, but also our students. So I'm going to step back and listen in and see how the Middleton Center can continue the conversation. But back to your question, Nikki, about equity versus equality in healthcare, and I'll be quiet for the rest of the time.
Thank you so much, Dr. Shanakin. So let's talk about it. I think in the interest of time, I'm just going to ask our panelists. I feel like now we've had a couple of meetings together where we're just getting to know each other. So this is just a conversation amongst friends and colleagues that we actually just have some people listening in on. So let's talk about it. Dr. Proctor gave us a great explanation and an understanding around equity in healthcare. So how are we having that conversation, the importance of equity in healthcare, as opposed to or in partnership with equality in healthcare?
Well, I'm Verna LeBoy, health educator with Columbia Boone County Public Health and Human Services. For 5 years now, I've had the pleasure of leading an award-winning public health initiative here in Boone County, Missouri, Live Well by Faith, where we're addressing health disparities in the African American community of Boone County through their places of worship, which is just very unique and has been played out very successful in our community, because the faith community, these people are volunteers. They're called lifestyle coaches, and they get monthly training and education. They get certification in evidence-based programs so they can lead their own programming in their churches. And they proved to be very effective when COVID hit and we needed to get the African American community vaccinated. They went to their churches and got people registered, and have had several successful clinics collaborating with university healthcare systems, Boone Hospital. I mean, this is just amazing. And they're all volunteers. They're getting health education. They're owning their health, even though they're dealing with, as Dr. Proctor said, pressure, stress, interacting with systems designed to oppress them. They're learning how to prepare for doctor's appointments, how to ask the proper questions and not leave until they have thorough understanding of the diagnosis and treatments. So we can't do this alone. We need systems, and that's why I'm so glad Nikki Magruder is at the university system right now, because she's from Columbia. She knows the people, and she's able to connect grassroots with the systems. And we're just getting started with these collaborations, but they've proven to be very effective and successful. So that's all. I tip my hat to Columbia Boone County Public Health and Human Services.
Thank you, Ms. Verna.
And hey, I'm Jeanette Berkeley Patton. I'm from the University of Missouri in Kansas City. I'm the director of our Health Equity Institute, and I also lead my research team, which is the Community Health Research Group. Our research team has been doing work in the African American community here in Kansas City's urban core for over 15 years. And similar to what Ms. Verna described, we've been working with the faith community and have also worked with many other sectors in our urban Kansas City area around health disparities. And the one thing that I can say from the work that we've been doing over these number of years, work that's been funded through NIH, through the Robert Wood Johnson Foundation, and through local foundations, is that our community's voices, input, experiential knowledge, and the many unique strengths in our community really has to be brought to bear on the healthcare system, and the fact that in delivery of health services, thinking out of the box and really trying to get to the heart of how can we increase reach and access of health services. Is only going to be improved when we can include our community. So for the work that we've been doing in engaging faith-based organizations along with other community-based organizations, we work with our community partners and our health agency partners across every single phase of our research processes. They establish what the research agenda will be around increasing access to health services, including HIV screening, STD screening, diabetes screening, dementia screening, mental health screening, and the many other types of health screening intervention research projects we've worked on with our community. They've been involved in developing the protocols. They've been involved in developing the intervention components. They've been involved in delivering the interventions that they have collaborated with our team to design. They even have been involved in the evaluation process. And I think in including our communities in work like this, in being true collaborators and having a voice at the table to really understand how do we begin to push prevention care and healthcare into the communities where people feel they can access various settings like the faith-based settings, where they can feel like they are in a trusted environment and where they feel like their voice is being heard. We're only going to be able to achieve that when we partner with our community organizations in the communities that we want to serve, and in that way begin to improve healthcare access.
Thank you so much. Ryan.
Yeah, so I would just, from everything the other panelists have just said, point out that their words and what they were saying is exactly why we need to use an equity lens versus focusing on equality. So equality would be, we treat every patient exactly the same, regardless of anything else going on in their life. And if we go back to Dr. Proctor's slides and think about those 9 systems that make up the social determinants of health, what we know is that folks are impacted by those social determinants in lots of different ways. The systems don't treat everyone equitably. Everybody does not have the same access to transportation or high quality education or income and wealth gaps. And so an equity lens to our work means that the care that we provide is tailored to what's going on in an individual's life, a community's life. And so when I hear talking about going out to community to provide healthcare services, that's necessary when you have issues with transportation where people can't come to you, you have to go to them. So that is really the difference between an equity lens to our work versus an equality lens, where it doesn't make in a perfect world, maybe that would work, but we know we don't live in a perfect world, and our systems that exist are infused and built with, there is issues of racism and sexism, and so all those issues at a systems level impact the health disparities of the of communities that we're trying to serve.
Thank you so much. And I think it's important that we help people understand the difference, which Ryan put together so beautifully between equity and equality. And the assumption, the flaw in equality is the assumption that everyone starts off in the same place, right? So we're all on the same playing field. We all have the same health issues and concerns. We all have the same backgrounds, and we just know that's not true. So thank you so much, Ryan, for just really sharing the importance of seeing equity in healthcare. And many times that means you're going to have to do what hasn't always been done and go out in the community versus waiting on individuals to come to you. So very important. And also, when you're reflecting on Dr. Proctor's slides, one of the most profound ones, or one that really resonated with me, is how he started the presentation with showing the map of where he came from and the differences and just sometimes just a few short miles, right, in life expectancy. And because not everyone understands that, and some may have seen that even for the first time. So it does call on us to do a little more research and homework to really understand the health equity and how you can be a part of the change that we need to see. So Dr. Proctor talked a lot about strong collaborations, and we've already heard from our panelists how important it is to the work that they're doing in their respective communities. But let's talk about that a little bit more. The community partnerships, collaborations. Dr. Proctor shared that MHA can't do it by themselves. These collaborations are necessary. Talk to us about how important they are in achieving our goal of health equity, and maybe even some of the things that you're hoping to see come to pass.
Well, Nikki, I'm really hoping that through the collaboration, the healthcare systems here in Boone County experienced in partnership with the public health department and our community lifestyle coaches through Live Well by Faith, that we will expand those collaborations because they work, setting up clinics and opportunities in these communities with maybe diabetes screening, A1C screenings, STD, all of it, everything, the whole gamut. It's time for us to bring the town and the gown together, so to speak, and meet the people where they are, because they've proven that they're motivated and they want to participate in their health and making healthy choices. So I'm hoping that, in Boone County, unlike Springfield, St. Louis, and Kansas City, they have community health worker programming. For some reason, Boone County doesn't. And people who are released from the hospital and readmitted, I heard through the hospital grapevine, insurance doesn't pay. So it would behoove us to invest in people, volunteers in our community that can be trained like community health workers. So I hope someone on this call is listening and will reach out to us here in Boone County and make a change, make a difference in our community by implementing community health worker programming to support the systems that are already in place to keep people healthy when they're released at home.
Yeah, we've been working through community collaborations for decades to accomplish addressing health disparities in the Kansas City area. And in particular with COVID-19, we expanded our work to include 4 sectors of the community to increase their capacity to be able to serve as community health liaisons. Almost in a very lay health type of role, but with the grant that we received through Jackson County in the state of Missouri, we were able to work with 60 organizations across 4 sectors of the community through the faith community, youth organizations, neighborhood associations, and businesses, and equip them with materials that they helped us to design tailored for their particular sector of the community, to be able to talk with their neighbors, their church members, their youth peers and families, their customers and clients about getting vaccinated for COVID-19. So we built an infrastructure to address vaccinations, and not only vaccinations, but providing other health services through the pop-up clinics that these 60 organizations are coordinating. And again, they've been equipped with training on how to talk to their peers about getting vaccinated, and they've helped to coordinate their vaccination events. And so with the structure, the infrastructure that we've built across these 4 sectors, with the community sector lead being partnered with the UMKC sector lead in each of these structures, we've been able to deliver over, I forget how many, 5,000 vaccinations and a countless number of health services at each of these vaccination events. Because for each of those 60 organizations, we've put on board the organizations, we've trained their community health liaisons, we've pushed out funding, and I think that's really important for us to talk about when we're talking about collaborative partnerships, that we as researchers or as universities and health institutions have to be able to push the funding out to these grassroots organizations that really are the foot soldiers in doing this type of work. And figuring out how do we sustain this work beyond the different grant fundings or CARES Act or Recovery Act funds that we have, especially when we're increasing the capacity of our community to be able to address health disparity issues.
So I would take a slightly different take on the question itself. And because within healthcare, providing healthcare services, absolutely, we need better collaboration, better partnerships among the organizations that are providing care, and doing that in a way that is community informed. What's top of mind for me related to this question, Nikki, is actual community members driving what are the issues? And I would take it a step higher than healthcare. I think about healthcare as services to the health of a community. And one of the things that we found, and I've been at MFH for 19 years, is that oftentimes we will be approached by an organization with a project idea. And one of the things we really want to see is the community saying that this is their priority? Are they saying that this is where they want some work done in this space? And one of the things we found is that, sometimes an organization with very good intentions will say, we need to do this project on high blood pressure. And then if you go and talk to community, they'll say, what we really need to improve our health is better paying jobs. And that often is a sticking point, especially for organizations that work in healthcare, is that they don't see those social determinants and those other systems like jobs or food as healthcare. And we really need to shift our thinking, because that is health. That is what is driving the health of our communities. And when we talk to community, which we really need, that's what I see as collaboration and partnerships, is where is the community voice centered in identifying what are their priorities? What are the priorities of the community? Is it clean air or clean water? Or, we see something like Flint, Michigan with the lead and the water crisis. What is community telling us is the biggest impact on their health and where we should start? Because that's where we can get momentum and see real change. But you have to have the buy-in of the community to really move the needle on the health of a community and not just providing healthcare services.
I love that, Ryan, and bringing in, of course, that wealth of knowledge and experience you bring from being with MFH for so long, and working with partners, because it is, we can sit in a room and we can make decisions for what we think the community needs. And we can come up with all of these wonderful proposals for how we're going to move the needle in getting our community healthy. And we do all of that without going to the populations we wish to serve and saying, hey, but what do you think? Are we on the right track? Or you tell us what needs to happen, what is top of mind for you. And I think that, to your point, Ryan, is so critical as we're talking about achieving health equity, because then I feel like I'm a part of what we're doing versus something happening to me, right? So you see value in me bringing my lived experience to the table and helping reach solutions. So absolutely. And another thing I wanted to point out from that group, for those responses, is Dr. Berkeley Patton talking about funding So if you're listening, friends, we do have to fund these healthy initiatives and start to think more creatively about how we can get this very important work done. We had someone in the chat say something, and I just want to mention this before I lose it, because Ryan pretty much touched on this as well. But someone pointed out that we need to work on the work that focuses on the whole system and not just one issue. So Ryan just talked about how really all of these systems work together. So if we're talking about health, but my blood pressure is elevated and I'm stressed out, and my mental health is suffering because I'm worrying about my low wage earning job, and I have more months than I do money to pay for all of the bills that I need to pay. All of that is interconnected. So really working on the entire system and working in collaborations with the people. So critical.
Real quick.
Yes.
Just a very quick thing I noticed, even at the opening of the Roy Blunt Precision Health building this morning, I walk around carrying a chip on my shoulder because I'm in the humanities, and sometimes we think that the humanities aren't an important part of this conversation, but it's absolutely is. One of the speakers this morning, and even the national, the NIH director, they both talked about the importance of health and society. And so we can't understand society without the humanities. We never would have understood what happened with Henrietta Lacks if there weren't historians doing that work to try and uncover that, right? So, I just wanted to bring in the idea of interdisciplinarity, which is an important part of this work as I sit in the academy, but also inspired by what Ms. Verna said about and we talk about this a lot, the bridging of town and gown. We can't, even in the humanities, do any work that is meaningful without understanding the societies that we study. And the societies are right outside the borders of this campus. So I am I'm very thankful again as the Middleton Center representative here to just listen in and be to be reminded of the important work that we can do as an interdisciplinary center.
If I could build on that, Nikki, because what Stephanie just said is so important about resourcing outside of the care delivery system. Dr. Proctor talked about our work in infant mortality. And we picked the Boot Heel and North St. Louis City and County because we saw an infant mortality rate for Black women, Black babies dying at 4 times a greater rate than white babies. And when you dig into the issue of infant mortality from a research perspective, yes, there is a piece of it that is inequitable access to care, lack of health insurance disparities, but the biggest driver of infant mortality for Black women is the day-to-day ongoing racism that they experience and what that does to their stress levels. So cortisone levels in African-American women are sort of always at an elevated level, and that impacts it leads to preterm births, it leads to low birth weight babies, but it is racism. And we have to acknowledge that, and we have to address it. And we're not going to address racism from a healthcare delivery perspective. And we've got to invest in other ways of addressing the issue of racism, because in this instance of infant mortality, it is the #1 driver of why we are seeing these rates of Black babies dying that is 4 times higher. And it's unacceptable. And we need to shift the resources to actually address the real issues that are going on. And I'll get off my soapbox.
No need. Thank you, Ryan, because you bring up This is a great conversation, Frank. So hopefully you're taking something from what you've heard this afternoon to start to think, what can I do? What is my part in addressing these health inequities? And so Ryan brings up, race being something that we have to talk about. And because of the work that I do, and many of us do, we know that is the conversation we would much rather avoid. But we can't, if we're talking about addressing health equity, we have to be willing to face the difficult topics because we cannot fix what we will not face. And so making sure that we name the things that we have to address. And I appreciate that. And I just wanted to say really quickly, because you may very well know someone that is impacted by some of the disparities that you've heard of this afternoon. I, for one, am a mother of 2 angel babies, where pregnancy, just the stress. And when I think about, you can't name socioeconomic status, I was a college graduate, working for one of the top financial firms in the country. I was doing well for myself, and still the stress of just being a Black woman in America and some of the different things that I was dealing with in corporate, now I celebrate with my angel babies, right, on their birthdays. So I think we have to just be really willing to pay attention and hear the story so that we can start to do the real work that's necessary. So thank you, Ryan, for naming that. Something that I want to make sure that, a couple of more things that I want to make sure that we address before we leave this afternoon. And in our preparation and planning time to be before you this afternoon, we had a great conversation about the importance of moving from just talking about it, right? Like, when can we take this from, yeah, we do need to educate ourselves. Yes, we do need to have more conversation. But when do we move from conversation to action? And what does that look like? So I would love for the panelists to just share with us some of your ideas around what the movement from conversation to action looks like.
Well, I can say that that conversation has to start, with the community. We've engaged community action boards to identify the health priority issues that they feel needs to be addressed. We've done health needs assessments with our community action boards, and actually they've helped to develop those assessments. And, we really try to principle the work on, you can't keep asking questions unless you're ready to take action. And so we combined the data that they help to, drive those assessments. We combined the data that we have from the city, from our assessments, and their experiential knowledge. And we created like a 3-year plan on how we were going to address the different health priorities that our community action boards have identified. And in doing so, how we're going to not only engage our community, but engage our health agency partners in this work. And so we are working on that plan. And I think that's really, really important because we know grants come and go. And the worst thing that we can do is to helicopter in a community, do the work, and then helicopter out. And then once the grants end, even if there was some benefit that was achieved from them, leaving that big gap in communities. And so we are really trying to work the plan with our community, since it was their voice that developed it. And along with that, bring resources to bear. And what we're finding is that as we do this work in collaboration with our community, with our health agency partners, that we have actually seen some processes, some practices, some procedures change in doing this work. And we've been able to see the capacity of our community grow, so that some of the things that they've done in collaboration with our work, they're out there doing it on their own. And I think that's one of the things that really needs to be stressed is, how can we begin to develop agents of change, people who are equipped with the skills, the knowledge, and knowing how to not only address healthcare, but how to address policies to bring about widespread change in our communities.
I love it. Will you be an agent of change? I love it. Absolutely. I want to read a couple of things in the chat. I don't want to overlook them. So there is an audience member that has suggested, and maybe the panelists have heard of the book. I have. They highly recommend a book called The Other Westmore, One Name, Two Fates. It's the perfect example of what Dr. Proctor described as multiple system failures that changes the trajectory of a young man's life. So definitely The Other Westmore, One Name, Two Fates is the title of that book that might give many some context to what we're talking about as relates to health equity. Another comment, as we were talking about community health workers, another comment made by an audience member is the Community Health Worker Association of Missouri is a great resource. They are a partner with the University of Missouri Extension. Another comment, language is so important, and we could spend some time right there, but it is important to understand. Language is so important. So panelists, we have a question from the audience. They would like to hear your views on how we talk about inequity and racism in Missouri.
Let me just say, this is a very difficult question. As a former chair of the Department of Black Studies at Mizzou, I know how careful faculty have to be when they talk about these topics. I remember some years ago, we started a program here at Mizzou called, it was previously called Diversity at Mizzou. It was for all our incoming students. It was supposed to be just a wonderful way of introducing them to what our expectations are. And immediately we got pushback because of the name of the program. So we changed it to Citizenship at Mizzou. So this question is a question I think about every day. As a scholar, as a professor, when I walk into class, I have to be careful what I say. And this is not unique to Missouri, but it is unique to Missouri, right? It is, of course, Missouri is part of a nation that is still grappling with a very long, difficult history. But different states are at different places on this journey to grappling, and Missouri has a ways to go. So the question is important, and that's just my take on speaking about racism generally. Now, as it relates to health, which is so important, I think it's even more. It needs to be more nuanced. Yeah.
I just have a quick couple of comments and discussions on race. I think first and foremost, we need to even tell just our personal stories. Nikki, I appreciate you sharing something so personal about your angel babies. I mean, we all have personal stories of racism and discrimination that we've experienced in our home cities and across the state. And so I usually lead with that. And of course, in many cases, many of my white counterparts have responses like, what? I can't believe that would happen to you. When I walk into a store, when I walk into a doctor's office, nobody knows who I am, but they do see the color of my skin. And I lead with those stories so that people understand that I'm speaking from a personal view. And from my personal view, it's probably the experience of many others. And then we can move into, the different frameworks and strategies to address racism. The other thing that I would say is that we really need to begin to think about how do we increase the pipeline of people of color to address racism. I mean, we have to think about how can we get more people of color in the healthcare system, working in the humanities in ways that are addressing health, in research that are in ways that are addressing health. And I say that because many times we have a very different perspective. Many times our experiences, I'm working in a community that I grew up in. So when I'm talking about doing work in inner city Kansas City, these are the streets, the stores, the schools, the churches that I grew up in. So even though I'm sitting in a place of privilege now, I still know that lived experience from growing up in those communities. And so we need to be able to nurture and grow up other people of color, other minorities that can move into these spaces and make decisions and have a voice about racism as well.
Thank you so much.
So I would agree 1000% with Jeanette, those comments. The only thing I would add is that we need, we need more white guys. We need more white folks to speak up. And we can't just, it's a big burden. It's a lot of weight to and Nikki breaks my heart. But we need folks to speak up. And I get emotional a little bit because I have an African-American son that we adopted. So I've seen, the way the world treats him, and it's tough. But we need more folks in the majority to speak up.
Thank you, Ryan. And both are so right. So I tell people all the time, your platform, your part in this fight for equity across the board might not look like mine. So you might not be in front of people, you might not be training and educating. Your role might simply be to educate yourself and then have those critical conversations around your kitchen table, those that are going to encourage others to do the same thing. So to Ryan's point, we need more human beings that look like him. To Dr. Berkeley Patton's point, more that look like her, like me, like Ms. Verna, like Dr. Shonican. Like, we need each and every one of you under the sound of my voice that are seeing this broadcast to figure out what is your role in advancing health equity. So Dr. Proctor gave you some things to start to think about, right? Like, what is your part? Because if you're looking at this and saying, well, that doesn't apply to me, they'll fix that over at the Missouri Foundation for Health, right? Like, they've got it covered. Then yes, they're doing great work, but what is your part? Like, what are you going to do? Because we all have a role to play in this desire for achieving our goal of health equity, each and every one of us. So I'm going to ask, we have maybe 5 minutes left. I would love to just ask our panelists if anyone else has anything else you want to share. Before, I'm sorry, 2 or 3, I was correct. 2 or 3 minutes. So you would need to be really brief in summarizing your last points. Otherwise, I'll close us out. Ms. Verna, anything you want to share?
Well, I'm honored to have been a part of this. I'm just hoping that we take our words and really hit the ground running and get in the trenches and take action. Do things differently. Reach out in your community and bring public health or healthcare systems to the people. Let's not just talk about it and read about it. Let's be about it.
Absolutely. So thank you, everyone. Once again, a big thank you to Dr. Proctor, as well as Ryan from the Missouri Foundation of Health, Dr. Shonican from the Middleton Center for Race, Dr. Berkeley Patton from the Center for Health Equity at UMKC, and our community's beloved Ms. Verna LeBoy from the Columbia Boone County Department of Public Health and Human Services. We hope that you will do your part in moving things forward, and that it concludes our time with you this afternoon. Thank you so much.
Wow. Thank you so much to Dr. Proctor, Nikki, and all of the panelists this afternoon. I know I learned a lot and I feel empowered, and I challenge each of you listening in to start this evening. What's one thing that you can do, even as one of our panelists said, starting at your dining room table this evening? On a day when we celebrate the opening of the Next Gen Precision Health Building, it's critical to a just society that the research and breakthroughs occurring under that roof are available to every citizen.